Welcome to Oncology Morning Commute, dialing down, optimizing third-generation treatments for CML. Morning Commute is developed in collaboration with At Point of Care and Projects in Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. What is the optimal dose for BCR-ABL1 TKIs for the treatment of chronic myeloid leukemia? Dr. Gerald Radich and Dr. Michael Morrow discuss this as well as treatment duration and other considerations for using third-generation therapies. Information about the faculty and disclosures can be found at morningcommutepodcast.com/CML3. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Radich is professor in the Clinical Research Division of Fred Hutchinson Cancer Center in Seattle. Dr. Morrow is a professor of medicine and leader of the Myeloproliferative Neoplasms Program in the Leukemia Service, Department of Medicine, at Memorial Sloan Kettering Cancer Center in New York City. I am Candace Hoffman, managing editor of Morning Commute. Dr. Radich will begin our discussion.
Hi, Michael. Good morning.
Morning, Jerry.
Amazingly enough, I'm commuting to work in a hot air balloon today. Just a novel approach. So there's that blow again.
I heard the gas. Yeah, you're
Yeah.
Stunning.
It's a stunning scene from up here. So great to run into you again. So let's if it's you and me, we're talking all CML all day, man. So one thing that I think is really interesting I want to talk about is how relatively lousy we are in picking tyrosine kinase doses. And the example that I would give first is with imatinib, where there's, I think, some thinking now in retrospect that maybe 600 was the right dose. Kind of in midpoint between 400 and 800. They kind of got the best bang for your buck without undue toxicity. I think there's some believers out there. Certainly dasatinib, we've been all over the globe, right? We start with 140 dailies and 70 BID, right? And then 100. And now there is some promising data out there that 50 milligrams a day is quite effective with dasatinib because you get more people taking the drug without interruptions, and they seem to be quite promising. And we know the tail of ponatinib, right, which may have started up a little bit higher than needed to, and kind of was a death of one company. And it's particularly interesting in a drug like dasatinib, where the half-life of the drug is 2 hours. So how the heck is it a once-a-day drug? So I guess that brings us to what in your practice is your actual starting dose for all of these drugs? For a usual person that walks off the street for imatinib, nilotinib, ponatinib, bosutinib, what do you actually do? And what kind of indications do you think about if you're going to do a higher dose versus a lower dose, et cetera?
Yeah, I think what you just stated, it tells this story about how we've grown up in this TKI era with CML. I think, roll back the clock, 1998, 99, phase 1 imatinib, it's chemotherapy days still. We don't have targeted therapy. So we're all worried about not maxing it out, just hitting the steep part of the curve, get to the top and don't go no further. And, didn't know what we could do. Wow, 300, 400 milligrams, starting at hematologic cytogenetic remissions. Then we chose you. I know you were a key player, birthing major molecular remission as a landmark and, making decisions. I was a little newer in the field, but I was under Brian Drucker's wing, and we were rolling patients on the study, and I think we learned a lot of things there. But then, quickly, you told the story about the second-gen inhibitors like dasatinib and nilotinib, where we went kind of guns a-blazing. Let's go full dose, full potency, because we really want to do even better. We were eager and not greedy, but I would say eager to do even better than we did with imatinib because it was so good, but it wasn't perfect. And then we had to throttle back. I think nilotinib, we started with 2 doses right out of the gate that were well tolerated in early studies, or it made sense based on the half-life. And then you mentioned the story with dasatinib's half-life that didn't actually make sense. Could you just inhibit the kinase for a short period of time and do what you needed to do? Indeed, we could. And then it got even, then it got a little bit more complicated with the drugs that came after that. Bosutinib was, had its own intrinsic toxicity concerns, very good drug, but clearly the higher doses were, brought more challenges, and ponatinib brought probably the most serious challenge. So that was my long-winded editorial for your wonderful remarks. But I could have just stopped by saying that my favorite dose of modified dose TKI is 600 milligrams of imatinib. I was always impressed by the data that the Australian groups generated, showing that if you wanted to be efficient with imatinib, you could perhaps use this dose optimization type approach. Start standard or start a little bit higher, and then optimize only those that need to. And in the end, you'd still have half people using imatinib and doing really well, and basically matching what you could do if you had started everyone on a second generation inhibitor. And you'd probably spared a lot of people some of the potential side effects they could have had. So my office and my clinic, I'm talking often about dose optimized imatinib. To be honest with you, I think we have to be cautious with nilotinib. I'm glad we have the lower dose as our starting dose, because there is a little bit of a dose response, and but there's also a little bit of a dose toxicity effect there. We mentioned in an earlier podcast about bosutinib and how the Assemble trial versus asciminib set us up for a little bit of trouble there. So I think we acknowledge we can get to the full doses of bosutinib, but we may want to start lower. And then you definitely shed some major sunshine on the dasatinib story. We've gone from 140 down to 100, and some people believe we should be down to 50 now. And we probably both have a lot of patients on kind of ranges of doses of dasatinib just to keep them well and in stable remission. So and then we got new drugs on the horizon with even with interesting dosing schemas too. So.
Just to think about ponatinib for a moment, there's various strategies that people employ, right? Some start low, work their way up. Some start high, work their way down. Some start in the middle, and then go up or down. And I think some of that depends on the toxicity, the comorbidities of the patient, and whether you want to live with the potential toxicities, especially cardiovascular. But also the duration of therapy that you anticipate, right? So it's if someone's getting a third line therapy and has no anticipation of going to transplant, so this is going to be their drug for life unless you move them to asciminib. That's one strategy versus if it's just a bridge to transplant, you just want to kind of debulk them, right? So how do you think that through? If you had a patient where you're thinking about ponatinib, do you basically just say, forget it, I'm just going to do asciminib and go from there? Do you say, yeah, I'm going to give it a try at whatever dose you prefer, and then if it doesn't work, go to asciminib? How do you work that through in your brain?
Yeah, I'm a little vexed by this problem because I think we've learned that ponatinib needs to have its dose lowered once we get into response. But I'm eager to get patients into very good responses. So I'd like to wait until they're in a deeper remission. And I think the recent trials with ponatinib, we went back to a dose finding trial essentially.
Yeah. Pretty far down the road to do that, but yeah.
Okay. Sometimes you got to go back a little bit to the drawing board and say, all right, let's just revisit this. But we learned that 45 milligrams probably really is still the optimum starting dose. So that means we have to risk stratify and manage the toxicity. We got to play by the rules and think about dose reduction. And you brought up those two scenarios. Do you want to bridge someone, or do you want to really kind of try to get them into safe harbor? Either way, I think you got to start at the full dose. The trouble with CML is you don't want to save drugs for the rainy day. Someone's progressing. It's not antibiotics. I think we've learned that strategy. Clearly, we know it's cancer. I don't want to simplify it too much, but sometimes we worry about that, and we're leery. So I think you just have to walk carefully, tiptoe through the tulips, and choose the right dose based on the data, risk stratify the patient. So in either situation, I probably want to use full dose ponatinib because I want to get both patients to the finish line, whether it's to a safe transplant with disease control or maybe longer term disease control. One of my most challenging questions is, what about long term ponatinib? And that's why asciminib really did offer a little bit of a diffusing capacity, because it may have slightly different niches that it's going to be performing best. Ponatinib is still a very good drug, but asciminib really offers some advantages.
Yeah, I don't know if we're really going to have to be talking about long-term ponatinib now that the symptoms are right. If somebody has to be on that long, maybe they shouldn't be on in the first place.
That sounds like a trial. We should talk after the podcast.
Yeah, we should be a trial. So one thing you brought up, though, is really a very interesting philosophical point. I think it's how patients or how doctors deal with these diseases. And I think sometimes because there are so many choices in CML, we maybe don't think this through carefully enough, right? So there's the infectious disease approach world, right, where you basically save your best drug for your back pocket, right?
Yeah.
And then you've got the oncology perspective, and I'm sort of not the average bear there since I'm a transplanter, which is basically, go everything big first, right? And I do sometimes worry like you that sometimes we piddle around a little bit with because we have so many options. But I say you have to think that in CML, the clock's ticking, right? In the old days when they weren't given therapy, everyone went into blast crisis after about 3-4 years, and it's a fatal disease. And so they still have malignancy. And I think especially once, my worry has always been with this disease is that resistance may be forever.
Yeah.
Once you become resistant, you're going to have multiple clones. It's going to be like whack-a-mole. And one of those is going to have a progression profile that's going to be, your end. So I think that my perspective, I think kind of here is once things don't go right on path, it's time to maybe not panic, but really think seriously that you've got a different disease here now.
Yeah, I couldn't agree more. I think that's why I use that philosophy, the rainy day approach. I think it really can rain pretty hard. It rains pretty hard in Seattle.
Yeah. And I still keep thinking, about there's been a few papers out there looking at things like gene expression profiling, where if you take people who are resistant to these drugs and you take people who have advanced phase disease, their gene expression profile is also pretty darn similar. Yeah. So even though the disease looks like chronic phase to the pathologist, that's not really what's going on in the cell. The clock is ticking.
Our best strategy is going to be to manage CML before the switches get thrown and patients have resistance mechanisms, just like you mentioned. That work is incredibly intriguing, Jerry, the expression profile work. I know you've done some of this where you see that chronic phase patients can look like blast crisis, wolf in sheep's clothing, I guess, for a little while, and then it's off. And then, the story about what other mechanisms may be underneath, are there yet other things that we could see, in the spectrum of myeloid mutations? I think there's some interesting questions there. But so when we're talking about dialing down the dose here, we don't want to miss the boat on choosing the right drug. We don't want to underdose the drug and not, if for the sake of toxicity. We need to remember to dose increase or dose optimize and not overplay the sparing patients from toxicity, although that is extremely important and it's literally like right there with efficacy and remission is sparing people toxicity. But I'm sure you see folks in the clinic that have been whittled down to non-therapeutic doses as well. So we have to be careful there. I'd rather see someone get switched to a drug, fit them to the drug that they can tolerate, that's going to get their disease under control and not allow them to have the switches get thrown and develop advanced disease. So
as one of my old mentors used to say, quality of life is only important if you're alive.
Well said. It goes from 100 to 0.
Yeah.
And that is really, it's a little bit of just a kind of a commentary, but we got to do a better job talking to our patients too, and them running a marathon of CML too, because it's long. Even the patients that are doing well. The studies of dialing down the dose or thinking about the dose are looking at optimizing once you're in remission. Ponatinib has a schema. Other drugs, there's been good data. The NILO-RED trial, looks at reducing nilotinib dosing, and for patients that are, approaching a TFR stance. I think that's some nice data. The dasatinib dose reduction up front, some have looked at optimizing dasatinib dose based on drug levels, based on response, based on certain cell populations like the elderly. There's a lot of good information out there. I always try to say to people to start with the label and then go from there and look at your patients and and do the best you can.
Michael, I'm going to have to wrap up here. You might hear we're kind of being blown off course here, our balloon here, and the guy's kind of panicking with the deal. So
dial down that altitude, Jerry.
It seems to be dialing it down itself. Cross your fingers.
Good luck.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/CML3. Look for all of our podcasts on your favorite podcast streaming services or download our Morning Commute app for your iPhone. Thank you for joining us today.